So today we're going to talk about acute kidney injury in ICU and only what you need to know. So my disclosures, I have on NIH grants. I did work with a Acute company when they did multi-center, multiple trials to first discover and then validate this biomarker. And my biases, I'm both nephrologist and intensivist, so that's for both group of fellows. I have my biases a little bit differently, so you need to think about that. Our learning objectives will to learn how to identify importance of kidney health and its effect on outcomes. We will describe the scientific evidence behind AKI biomarkers, and we will see how we implement that and how we have developed protocol in this institution for AKI standardized approach management, assessment and management. Key points. First part. AKI is one of the most common hospital complications with lasting consequences. Kidney health must be assessed at the time of ICU admission or hospital admission or pre-op, wherever you are working, using history, estimated GFR and urine dipsticks at the minimum. AKI should be diagnosed and staged using consensus criteria, so you need to learn them. We're going to go over them. And kidney can acutely suffer from many different causes. Primary prevention is the key for us. That's what we can do the most impact. But then if we can't do that, mitigation of injury or progression up towards more severe stages, and then enhancement, renal recovery is another goal we need to focus on. So here's like one of those diagrams of pathophysiology. I like to show this to nephrologists because they like all of these things. Okay, so you get all of these wonderful interactions and then you get a patient, right? And then, so here's the guy, 80 years old, had a Whipple surgery, he had history of CKD, his admission creatinine is slightly above his baseline, it's 1.26. You get this guy, he's not making urine for 3 hours or making less than, 30, 20 TCC, he had hypotension in the OR and he got nephrotoxic drugs. So what do you do? Does he have AKI? Is this CKD? How would all of those factors now work for you? What do you do for this guy, right? I mean, it's not so black and white. This is the patient where you maybe can change something. So how we do this? So this is just showing you that this is incredibly complicated, and because it's so complicated, it's not done properly, or it's just passed by. So what is AKI? It is a clinical syndrome, right? It's not, and it has multiple causes and multiple presentations, and that's why it's hard. For the diagnosis of AKI, it needs to be diagnosed, the condition needs to occur rapidly, hours to days, and results in decrease in renal excretory function. That's what we focus on, right? Creatinine, although kidney has many other functions. Don't forget that. Accumulation of the waste is a hallmark of the pathophysiology, so you're going to get accumulation of the nitrogen metabolism, metabolic acids, and potassium and phosphate. Most commonly is what we focus on, right? Because the kidney is major clearance organ. And sometimes you will have decreased urine output, but often in ICU you don't have decreased urine output because you just give a lot of fluids and you don't get that. Defining AKI, back in 2000, long time ago, before we get the consensus criteria, there were all kind of definitions, and sadly we still have all those kind of definitions. You can see people go around and trying to say what is AKI if you use creatinine and urine output. We don't do this anymore. In Rifle was published in 2004, and it stands for risk, injury, failure, loss, and ESKD. It has criteria and outcomes. And if you are not familiar with Rifle or KDIGO for that matter, you should read about it. But basically, you will have not just criteria to define AKI, but you can then stage AKI depending on what's the maximum change in creatinine or decrease in urine output you achieve. This was done, we'll go over more in 2004, and then Aiken came and said that it's not always 50% change from baseline, but you can just use 0.3 milligram per deciliter change as a criteria, and then KDIGO put this all together. So you can define AKI by either of these three criteria. Increase in serum creatinine by 0.3 milligram per deciliter within 48 hours. So it has to be 48 hours window. So anytime in a 48-hour will creatinine go up 0.3, that's AKI. Or if you know the baseline, you need 50% increase from your baseline presumed or known to occur within 7 days. So you have some flexibility because sometimes you can get patients and you have no idea, right? Like guy. We call that community-acquired AKI. What if he comes with elevated creatinine and you never know what was baseline? What do you do then? Most common situation is that. And then urine volume has to be less than 0.5 milliliter per kilogram for 6 hours. That's why it's really important in the beginning watching that urine output continuously. And looking at the urine output not necessarily as an absolute value, but mil per kilogram, right? It's not the same for tiny little person and a huge person. And then once you hit the criteria, then you stage them. Then you go, where does my creatinine go, how high? So once you triple, that's stage 3. If you double, it's stage 2. If you are less than double, that's stage 1. Anytime you're on CVVH or RRT, that's stage 3 no matter what, right? Once you're on renal replacement therapy, that's stage 3 no matter what. And then you look for so then we are bringing new guidelines you don't see there, but now we will introduce persistent, rapidly resolved, and recovery and all of that. So once you diagnose somebody, you have 48 hours for that to resolve. Because we know if you get AKI in 48 hours, you start showing recovery, you do much better. So that's why we focus on the first 48 hours. You do whatever you can. If the AKI starts resolving, that we call rapidly resolved. If the AKI persists, meaning stay the same and go up, that's persistent AKI. Persistent AKI that in the first 7 days does not resolve is acute kidney disease. And acute kidney disease will require 90 days follow-up to stage for chronic kidney disease. So everybody who developed AKI does not resolve in 48 hours, become persistent AKI, get discharged without recovery, meaning coming back to your baseline, will be acute kidney disease and will need 90 days follow-up with somebody, because if in 90 days you are not back to the normal GFR, you will be called chronic kidney disease. And that's where we miss a lot of people, right? So that will be how we will structure the follow-up. So in this hospital, we have acute AKI clinic. So every patient you discharge with AKD, and you're going to stage them same as AKI, right? Stage 3, tripled creatinine. So you are still above threefold above your baseline. If you are still between 2 and 3-fold above your baseline at the discharge, that's stage 2. If you are less than 2-fold above your discharge, so you are between 50% above and 200%, right? Then you are called AKD stage 1 and you still need follow-up. So just keep that in mind. For everybody to be considered recovered, they need to come within 50% of their baseline at the discharge. If they are not there, they are AKD. They have acute kidney disease. Okay? So something just to keep that in mind. And they require follow-up with AKI clinic. Diagnosis, we just went over that. So just one more time, rise in serum creatinine of 0.3 milligram or greater within 48 hours or 50% or greater or presumed in 7 days. Okay, 2 criteria. And then urine output fall to less than 0.5 per kilogram per hour for more than 6 hours in adults. And that's why you need to monitor closely creatinine and urine output in the beginning to get all of that. So why does it matter? AKI is the most common postoperative complication when you define like this, right? If you define it as a need for dialysis, well, yes, it's not as common. But most common when you define by consensus criteria, and you can see it goes as from 10% in OB/GYN, mostly GYN, all the way up to 50% urology, transplant, CT surgery. It's subtle, meaning the stages 2, 3 are the most common stage. Stage 1 and 2 are the most common stages. And you can see that here the stage 3 on dialysis is a very small portion, right? But we tend to see that the most and focus on that. The low awareness is something that we need to improve on. So this is looking at the patients who actually had mention of AKI in their discharge summary, and you can see even if you have even among the patients with the most severe AKI stage 3, only half of them had mentioning of AKI in their discharge summary. So what happens, you get the disease that it's never mentioned in your discharge summary, it never enters your record, you don't see anybody for that, you just leave. And what happens to you, I'll show you after that. What happens is that your risk of dying is significantly higher than somebody who didn't have AKI. So this is our data. Patients who never had kidney disease before surgery had AKI, and even those who completely recovered at the discharge has significantly lower survival long-term than patients without AKI during hospitalization for major surgery. So at that time, when we first published this in Annals of Surgery, that was in 2009, we didn't know why do these patients die. But not just that you die, but also the cost is incremental with AKI. Not just stage 3, but any stage of AKI. And it can range between extra $9,000, $26,000 per episode, right, for AKI, even when you adjust for other complications. So why do you die? This is a paper that was just published in Annals, where we looked what is the cause-specific mortality, and it's a heart disease, right? So patients with AKI have similar increase in cardiovascular mortality to the CKD patients. They have known doubling of cardiovascular mortality over normal people. So if you have a chronic kidney disease, you are more likely never to develop end stage, never be on dialysis, but you are more likely to die from heart disease, right? So usually CKD patients, they don't die from dialysis. No, they die from heart disease. So that's why the CKD is unconventional cardiovascular risk factors. And now we understand AKIs also. Why is that pathophysiological? Is it because you progress to CKD and nobody knows? Or is it because your endothelial is damaged? That's still to be understood. But something very important that you need to think about that. As a matter of fact, when you look at the general population and look what's the biggest predictor of longevity is your estimated GFR and your proteinuria. So if you want to be healthy, check your urine and keep your kidneys healthy. So why is kidney so important? So here is it. So first of all, what is kidney? The kidney is a perfect blood scrubber. So if you think about it, how would you guarantee that you can remove any bad substance from your blood, but you would have to filter your plasma, right? You say, okay, something is in my blood, it comes from the, how can I get rid of that? You just filter the plasma. As a matter of fact, kidney does that 150 times a day. You filter your plasma, entire plasma, right? Kidney produce about 100 to 200 liters of ultrafiltrate a day. So your blood goes through the genome, glomerular. You produce ultrafiltrate, 100 to 200 liters of ultrafiltrate. Now, do you make 200 liters of urine? No. How much urine you make? 1 to 1.5 liters. So most of this ultrafiltrate is reabsorbed back, right? Keeping what's good and getting rid of what's bad. So the entire plasma volume is filtered every 30 minutes. That's how good it is. So 99% of this filtrate is reabsorbed. So obviously proximal tubular cells that reabsorb all of that are completely exposed to everything in the blood constantly, every 30 minutes. So every toxin, every damp and PAMP, right? You heard about damage-associated molecules that comes from the bacteria from environmental toxins go on proximal tubular cells. So they are faced with a lot of toxins and exposed to the stress. So not surprisingly, idea was that you can use the urine as an indicator of the tubular stress or tubular health because it's always in the contact and it's also concentrated. So with that idea, a bunch of people who does critical care nephrology said, okay, let's put all known biomarkers that were described in literature and just pick up some of them, 100 of them, and test them in the patients when they come to ICU before they get AKI and see whether some of them can predict development of AKI. That was our first study, discovery and validation of these biomarkers. We tested many of them and identified 2 biomarkers that are related to cell cycle arrest that reflect distress of tubular cells, because tubular cells, when they're exposed to the DNA damage or stress, they enter paralysis of the reproduction, right? They stop reproducing, the cell cycle arrest, because environment signals that it's not a good time to reproduce, right? Now that arrest of the reproduction, cellular reproduction is good on the short term, but long term is not good, obviously, because the cell enters this senescence and dies and becomes fibrotic. So what we believe is that these biomarkers early signal stress, and they are overly expressed that may signal overwhelming stress that now kidney cannot overcome and then progress to injury and damage, right? So this is the initial comparison of this biomarker with other biomarker, and you can see that it was tested against NGAL that you probably heard about. That was tested in a pediatric cardiac surgery as a biomarker of AKI. KIM1, well-known tubular damage marker, and other IL-18 and GST and FABP. All of them are biomolecular signatures of tubular cell damage. We validated this then in another cohort, and based on this validation set, the test was approved for clinical use by FDA. Now, to understand how to use the test, you really need to review the studies. So the study was the 420 critically ill patients. To get tested, you need to fulfill these criteria. You need to have a cardiac SOFA greater or equal than 1. So MAP less than 70. You have to have a respiratory SOFA greater or equal than 2. That's PF ratio less than 300. Not necessarily intubated. And then you could have KDIGO stage 1 or CKD 1 to 3, but not stage 2 and 3. So you could have mild AKI, stage 1. But if you already have 2 or 3 AKI, you have AKI. So what you were trying to do is really predict whether these patients will progress to stage 2 or 3, or whether they will develop de novo stage 2 or 3 in 12 hours from the test. Okay. And then in 12 hours, you would adjudicate clinical stage 2 or 3 AKI. Remember, that's 2 times baseline increase in creatinine or less than 0.3 milliliter per kilogram for 12 hours persistent. Test performed well. So if you have a test of 0.3 and greater positive, your chances of developing AKI in 12 hours were 1 in 3 as opposed to 1 in 25 if you have negative test. This was subsequently tested in a cardiac surgery, and you will find all these papers. And in the surgical patients, performed well. The test did well both in non-cardiac cardiac surgery, in emergence versus elective, also in the sepsis very well. And now there are studies showing that it does well in a patient with a chronic comorbid conditions. It does not necessarily get higher just because of that. Okay, so what do we do with that? So once the test was approved, really, we piloted it in a SICU here with the idea that you can't just use this test randomly because it's not going to help you. Think about how we use troponin in BNP, right? Do we use troponin optimally in ICU? So if you think about that, how was troponin developed? There were people with chest pain, right? There was a chest pain, there was EKG changes, there was a pre-test probability, right? It was increased, and then the test get done, and it was diagnostic test. Now, troponin is diagnostic test, right? It diagnoses damage. This is a risk stratification test. So you are not diagnosing AKI, you are just identifying risk. 2 different things. So if you use BNP, we use, again, with the idea that we can diagnose volume overload, right, or heart failure in ICU. Again, suboptimal because the test was validated for ER patients with pneumonia versus heart failure presenting from outpatient, right? Then you get ICU patients that are completely different. So none of these tests is really perfect diagnostic, especially BNP in ICU. However, BNP is a very good prognostic test in ICU. It very well prognosticates who's going to die. So I can tell you, no matter why you have high BNP, I'm more likely to die in ICU. One of the best tests in sepsis prognostication of the mortality. But it's not diagnostic test for heart failure. So always think about it. Diagnosis versus risk stratification, 2 different things. So we're going to talk about risk stratification for AKI. Okay, so here are the key points I want you to remember. Risk for AKI can be quantified, even using clinical data. We can improve then risk stratification using clinical biomarkers on the top of the clinical data. We can prevent AKI. We can mitigate progression. We can also decrease the effect of the AKI on other organs, especially lung and heart. And then we can facilitate recovery. These are our goals. This is what we want to achieve. So for clinical risk assessment, we are trying to develop tests that use data that is there. We will not have to do anything else. If we can apply it to every patient, we can automate it. And we work on this something called Gatorade score, whatever. We are still working with it. Generalized susceptibility risk index, Gatorade score. We have all kind of names. But what we want to measure is susceptibility and exposure. So you have to think about every complication that occurs in ICU or after surgery as a combination of your susceptibility that determines your resilience and exposure or stress imposed either by critical illness or surgery, right? So if you take ICU and you expand this, right, we are doing acute care medicine, right? Acute disease. We are dealing with acute diseases here. Either you get a surgery, or you get trauma, you get hit by the car, or you get sepsis, something acutely bad happened to you. But you already have some level of health, right? You are either very healthy, or you think you are, or you are sick, but all you can say, you are sick. You don't have so there is no very good quantification of health, right? Would you agree with that? In this room, who is the healthiest person? Is there a way to measure that? We don't, right? We don't really have the way, right? We don't. We only measure somehow disease. We define health as the absence of the disease. And it's a category with no quantification. I'm hoping that we will get better and start quantifying health, really. But even how do we quantify disease? How do we quantify, when you see a patient with a chronic disease, how do you quantify how sick they are, except that you write sick? Well, what do you use? What do you use when you admit somebody to ICU? What do you use to quantify existing disease severity? Apache is one way, but Apache is not chronic score. Apache is acuity. It's more a score to measure combination of acute disease exposure with, right, it's more exposure score. It has some component of chronic illness. Remember the Apache has like age, like comorbid condition a little bit. It gives you some points on that. What else do you know that you heard that measure chronic disease, quantifies chronic disease? You heard about Charlson Comorbidity Index. Probably not much, but there is something called Charlson Comorbidity Index, where people were trying to say all your comorbidities together with some weights from epidemiological data give you some index. So if you have an index that is low, like 1 or 2, that means your comorbidities are less. Or if you have 10 or 12, that's really bad. It's a very big burden of comorbidity. So obviously not everybody is same way sick nor same way healthy, right? It's just that we don't understand how to do that. It doesn't mean it doesn't exist, gradation. So what we really want to say, for every organ you need to think about it. So how healthy is your kidney? So what determines your health? So these are some of the things you can think about that, right? So you can have a simple things like, yes, age is obvious risk factor because the organs age. Now some people age better, some don't. So it's just partially important. Then we could say how we can measure kidney health by maybe measuring your estimated GFR. That's a good way to do that. Rather than just looking in your creatinine, you can estimate glomerular filtration rate, right? That's very important. You can look at the urine. I mean, if you have proteinuria, that's a sign of not healthy kidneys. Very cheap test, dip it. You can see some cells in the urine. We are developing quantification of the cellular RNA and vesicular RNA to look at whether we can read about tubular cells held from the urine. That's coming, all this omics. But you can also ask, do I have a risk factor for kidney disease? What are the most common risk factors? Hypertension, diabetes, right? Those are well-known. Chronic liver disease, heart failure. Those are your big things. Ring the bell. If you have this, kidney might be hurt. So we want to quantify susceptibility, and then we want to quantify exposures. Now, exposures are different between different ICUs. In our ICU, what are the exposures for us? Number 1, hypotension in the OR. Any hypotension in the OR is bad too. I'm going to tell you, every hypotension, meaning even less than 70 for a long time can be exposure. It's a combination of how low and how long you go. So we always look at a hypotension in the OR. We were very conservative in it, but I will show our risk score. So we are looking for extreme hypotension. but be cognitive of any hypotension. So for me, everybody who come from the OR, you should look at their OR record. Pull the OR, pull the graph, look at where the pressure was. You will be surprised. On induction, at the exit. Usually I see, I'm not an anesthesiologist, but most of the day it's at the beginning, at the end. Like, you can see, they start with no A-line and suddenly A-line appears, right? In the middle of the case. Look at the, never. Look at the pressors. Do they get pressors? All of these factors, very important. Intraoperative record is a black box that needs to be opened, right? And it's very important and determines outcomes for our patients. Then infection, sepsis, well-known. Sepsis is well-known risk factor. Basically, 80% of patients with sepsis and they have AKI at the end. Hypovolemia, severe dehydration, maybe if you're in a MICU, you admit these patients. Nephrotoxins in a MICU, not here. Surgery, we talked about that. Big traumas with us. Drugs in the MICU, a lot. Hepatorenal, like chronic liver disease, heart failure in the MICU. So every unit can develop their own exposure, badness bundle. Okay, so what next do you do? So what we are trying to develop here is as of now, everybody that you can go to EHR and find your estimated GFR. You know that, right? In BMP, with every creatinine you see eGFR. And it's the good one. It's an MDRD eGFR. You should use it. Just go there. It tells you. But it's only good when you admit the patient or in outpatient setting. Once you come here and you start getting changes in creatinine, that GFR is not good anymore. It's only good one time because it does not incorporate dynamic change. So there's something called kinetic GFR that incorporates that mathematical relationship of the change. So what we are trying to develop is the alert at AKI EPIC that will give you every day the stage of AKI and kinetic GFR for each of your patients. So we're working on it. But other people have worked on that. So in Yale, they did a randomized controlled trial where they did the same. They said, okay, every patient gets AKI diagnostic, right? I'll call Dr. Greg, text message. Dr. Greg, your patient have AKI stage 2. You get a text. So they randomized doctors in 2 groups. You get a text, you don't get a text. And guess what they found? There was no difference in outcomes, but there was no difference in what was done. People who got text didn't do anything different than people that didn't get a text. Does it surprise you? No. 0, right? Alert itself is not enough. Alert, so that's why when we thought about how do we implement this, it has to come as a pathway. It comes as a whole product. It's not just what you get, but what do you need to do after that? Because what you need to do after that is complicated and not always clear, not even to experts like me. So what we did is took KDIGO, you heard about this Kidney Disease Improvement Guidelines Outcomes Group. So they have them for the CKD, we have them for AKI, we have for all kinds of kidney disease. They have all of these consensus guidelines. Guidelines exist. They're very obvious, right? But I'll tell you that most of the people don't follow even these simple, obvious, common sense guidelines that you think you do all the time. You don't. So what we did is put this together and develop our RED CPR protocol, where we develop stepwise approach where you look at the susceptibility, look at exposure, develop the stress, look at the distress, and do a bunch of stuff. So how do you do that? So first, this is for fellows. That we, Justin and me are finishing this in an admission note. There's a separate note that you can do anytime when you have somebody crashing. Let's say you have a patient who is not a new admission, but he's developing new sepsis, he's developing hypotension. You can use this to assess for AKI. But for every new admission, we're going to have that in admission notes. So in your admission notes for your kidney, renal, electrolytes, whatever you call that fluid. So you're going to take it and you're going to assess with a little boom, 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 and it's produced score for you. And it's not hard. It's really based on this. It asks you this. Do you have history of CKD? Is your GFR less than 60 on admission? Is this protein in your urine? And it's trying to pull from EPIC everything, right, by itself. Is the urine less than 0.5 for 3 hours, all these points, and then do you have sepsis, do you have hypotension, do you have hemorrhagic shock, are you on ventilator, is your PF ratio low, did you get vanc, did you get contrast? Pull that, give you a score. You got a score, and if your score is less than if your score is 3 and greater, so it has to be 3, you order NephroCheck test. You go on order and you get NephroCheck. If the score is less than 3, you don't do anything. You just say that's fine. Low clinical risk for AKI, focus on other things, kidney looks okay for now. Exposure and susceptibility together did not reach consensus, did not reach critical mass, right? Low pretest probability. If the risk is greater than 3, you will order NephroCheck. And then NephroCheck will come, and if the NephroCheck is negative, that is less than 0.3, you will say this is low risk. Maybe it's a high clinical, but the low stress on biological marker. Proceed with usual care, low risk for AKI, other issues are priority. Give diuretic. If the patient is not making urine, give them diuretic. They probably have too much ADH on board, as some of them do. Focus, you need to extubate patient with a lot of fluid, diurese them, please. They are not making urine because of other reasons, not of the kidney AKI, tubular damage, maybe from ADH. So then other things become priority. Now, if the score is greater than 0.3 NephroCheck, but less than 2, we call that moderate risk or high risk, however you want it, because the next group we call very high risk. So this is a high risk by biological marker. You start A, B, C, D, E. I mean, really the basics. And call A, B, C, D because it's basic, but you need to do it. So you're going to continue to monitor urine output, creatinine. You're going to optimize blood pressure with the emphasis on optimize. So that means if your patient is somebody with hypertension on 3 blood pressure meds, you're going to know that. Because for those patients, perhaps MAP of 65 is too low. You know, they might need a little bit more. Maybe you need to hold their ACE inhibitor, whatever, you know. You will have these patients. You need to bring that, personalize that optimization. Then you're going to do your volume, whatever needs to be done. You want to do TTE, you want to do CVP, you know, do it. But these are not regular patients. These are patients at high risk, right? 2 factors now. Adjust your drugs. Assume that the GFR might be going down quickly. So, you know, ask yourself, do I need vancomycin? Do I need to do contrast right now? Or it can be done in 12 hours. I'll ask all this question and evaluate again in 12 hours. And repeat the cycle. In 12 hours, after you've done everything right, creatinine should not go up. It should stay the same or go down. Right? You did all this, you give fluid. If it's going up, it's not good. You know, something is going on. And then if your risk is, if you are greater than 2, that implicates very high risk. Now you need to move quicker. Not just do your ABCD, but start thinking, why is this? Start thinking, this might progress quickly. You'll see patients like that. Usually, I'll give you an example who gets this very high risk. You're going to see their context is different. Now you need to more focus on what's diagnosis needed. Do I need to know? Do I need to involve nephrology now? Earlier, and have them do these tests, and maybe this is going to progress quickly. Maybe this needs CVVH or renal replacement therapy faster than waiting for me to be completely failing, right? And getting volume overload. And the key is here that you don't end up being on starting CVVH with 10-liter positive, 20-liter positive, because we know that those patients don't do well. Significant volume overload with AKI is another risk factor for dying. Significantly increase your risk of dying with AKI. So this is just what we have seen in our, and we've done this with Justin. About half of the patients had high clinical risk, and then of those, about 1/3 has negative NephroCheck. So you can see that a lot of people get excluded, actually. You rule them out. And then with those with positive NephroCheck, quite a lot of them ended up going to stage 2 or 3, but interestingly, we were able not to have anybody on the dialysis. Nobody ended up on dialysis. So you maybe progress, as I say, you mitigate progression, you arrest it there. and then the kidney slowly regenerate because kidney can do that. But kidney that is in a heavy stress now get 10 liters of fluid in swollen kidney, just like another organ. You are giving them other drugs and it just doesn't have a chance to regenerate. So common scenarios, just to illustrate. Here's a time when it helps you to rule out. Right? These are very good rule outs. Notice all of these patients are similar. 70-year-old guy, complex spine surgery, history of CKD, baseline 1-1, ICU admission, creatinine is 1-3, patient intubated, hypotension, enlarged, resuscitation in the OR, he got like 10 liters. He had spine surgery, he comes out, he has no cuff leak, they didn't extubate him in the OR because of the swelling, his score is 4. He qualified for nephro check. Okay, you send test. What do you do on this guy? Next patient is Whipple, also 70 years old. Again, creatinine is 1-3. He has no previous history of CKD. It's abnormal, obviously. He had hypotension. He got nephrotoxins. His score is 5. You set test. Another guy is 80 years old guy. He had CKD. He had vascular surgery. He's above baseline, about 1-3. 1-3 is a magical number because it's no way. It's not 50%. You know, you don't know. Oliguria for 3 hours, maybe making 30 cc. He also had hypotension, though he had nephrotoxic drugs. His score is 7 clinical. All of them got nephrocheck. Now, if you now know that I'm not testing you for knowledge, what do you think most of the people do when they get cold at the bedside? What do? They get fluid. Most of the people get IV fluid, plasma, like 500 cc balls, right? Give him some balls. Later. Right. Guess what? None of these patients, all of them were negative. Nephrocheck. All of them. So, I mean, I was on service, so it's kind of easier. I know. I thought, we test. I said, okay, so we gave diuretic to all and extubated. We said, okay, forget it. Let it go. Let go. Don't give fluid. Do not give fluid for urine output. Like, I mean, as I said, urine output is not a disease. Right? It's a physiological sign, symptom, whatever you call, like a heart rate, right? So important. Here you can say, okay, negative test, what do? You focus on another organs, you forget the kidney. Okay, use diuretics. It's okay to diuretics patient post-op. Remember, we are talking about admission to ICU. This is like admission. You just got in. Help us for ruling out. They had hypotension exposure, but they are now in ICU. They're okay. But they have all these exposures, and now you're now deciding. You're not going to see this. These are all for the intensivist. You rule out these, you move on. Okay. These are easy, right? We are now preventing doing harm to patients by doing unnecessary waste. Remember that we know that 5 things, choosing wisely. You heard about that campaign, choosing wisely? If you haven't, read about that. 5 goals on choosing wisely for critical care was related to the waste. Too much care, hurting your patients. Do not order daily labs, do not give a blood above 7. These are common things that we do all the time. Okay, let's move on. So let's talk about now, what about very high-risk patients? I'm just giving you extremes. Only 8% of all our patients. This is not NICU. I have to warn you. This is ISSI. NICU will be different. I don't know, we didn't do that yet in NICU. So here we had patients who get nephrocheck very high, greater than 10. 62% of these patients are actually stage 1 AKI when we saw them. And almost 40% of them had CKD. So that means that most of these patients have high susceptibility. You got that, right? So it's now a combination of exposure susceptibility. Higher your susceptibility, more likely that your stress will be huge. That makes sense, right? I mean, that's really common sense. Okay, so 87% of them progress to stage 3, but nobody end up on RRT. And we had a complete recovery of 40%. But see, even with everything we've done right, only 40% of patients will recover. This is disease that needs long-term follow-up for the renal fellows. You see that? These patients need to see nephrologists. So here are 2 patients who had very high risk. This one, 77-year-old male, baseline creatinine is 0.75. He was admitted to ICU for intra-abdominal severe sepsis. His exposures were, he was intubated, he was hypotensive, Before he got a contrast, he had severe sepsis, his serum creatinine was 135 on admission. Okay, his score was 10, clinical score. His nephro check was 3.16. So what did we do differently? We know that he had PICC line with a gram-negative, already known growth when he was admitted. He was admitted, we started TTE, we guided our fluid with TTE. We actually changed his vancomycin. We wanted to ask ID to change it that non-renal, because vancomycin is a toxin. Just keep that in mind. It's a toxic. It's more toxic on a higher level, but it's always toxic. You said, but there's no evidence that vancomycin is toxic. Wrong. That's okay. And we said, fine, we're not going to give it because there was no justified indication. There was no growth nowhere. We knew it's a gram-negative bacteria, but they said, well, he doesn't need it. I said, well, he doesn't get it immediately until we know what happens to the kidney. We hold it. This guy ended up progressing to stage 3, but never ended up on dialysis. He plateaued, and then he came down. He never was volume overload. He was never intubated. He was extubated. He never ended up on dialysis, and he never needed vancomycin, really. So you're reflexive, sometimes we do reflex, we give things without, maybe they really don't need those things. Here's the second guy, 64-year-old male, baseline creatinine 0.96, again, sepsis, abdominal surgery. You're going to see these the most, abdominals, right? Again, intubated, sepsis, creatinine 1.45, clinical score was 8. His nephro check was 3.58. Similar transthoracic echo, we actually called early nephrologic viscosal because he went to stage 2. He had echogenic kidney and thin cortex, indicating that he actually had some CKD probably. That was unrecognized, right? We held contrast. We said, no, he does not get a contrast. It was just one of those things that surgical fellows said, we want to see intra-abdominal. And I said, well, how high is your suspicion? Can it wait? And they say, yeah, it can wait. So we're not going to give the contrast. He didn't get a contrast that day. He progressed to stage 2, stayed there, and recovered in 2 days. He was back to baseline, right? So it's hard. Prevention is hard because what you do, you impede outcomes of occurring. But what we are doing right now, we're going to compare all of these patients matched to propensity matched historical controls, and we'll see whether we can show that the progression was really objectively stopped here. But something just to keep in mind, right? You can ask that question. If this is really now priority, my kidney health, do I need the antibiotics? Do I need contrast? Simple things that you can ask and delay. If the answer is like, I absolutely have to do this because the life depends, then you need to be smart about that, right? You need to do quick, you can try, and I have succeeded in that, to talk to ID not to give vancomycin, go with linezolid. If you say, well, this is really, you can make your case for linezolid. We offer that as an option. For contrast, if you really have to give the contrast, but I'm going to ask ourselves, so when really we need to give the contrast? Let's say you need to do CAT, we have a case like that. You really need to go and give them a stent. You have some strategy that are not randomized control trial. They are maybe anecdotal trials that you can use. With mucomis, with dialysis after contrast, all of that exists. So I think at this point, in this very high-risk patient, you need some help from nephrology. This is where we want to start thinking early consult, maybe early RRT for some patients that you cannot stop from progression. There will be people who had such a big insult that you can't do anything. But you can prevent being 10 milliliter positive. You can help them get that acidosis off, fluid off, and help other organs not progress in a failure. That's it. And this is just my group, my research group. Whoever wants to do research with me can find me. We have a lot of cool stuff going on. And that's it.